Good evening, everyone, and a very warm welcome to the session of Critical Care Conversations. And today we are addressing a topic that every intensivist is increasingly confronted with, that is resistant gram-negative infections in the ICU. So, resistant gram-negative infections remain one of the most challenging problems we face in the ICU today, often leaving us with limited therapeutic options and difficult clinical decisions. So, I'm truly delighted to be joined by an outstanding panel of experts who bring immense clinical experience from across the country. Let me briefly introduce you to all of them. Dr. Ashit Hegde, everyone knows, is consultant in medicine, head of medicine at Hinduja Hospital. Then we have Dr. Subhash Todi, sir is medical advisor and director critical care at AMR Calcutta. Then we have Binila Chacko, she's professor and head of division of critical care at CMC Vellore. We have Dr. Prakash Shastri, who is going to yet to join us. He's senior consultant vice chairman, Sir Gangaram Hospital. Then we have Monalisa Sahu. She's an infectious disease specialist, DM in infectious disease, senior consultant, head of department of infectious disease, Yashwada Hospital, Hyderabad. We talk of the MDR, XDR, PDR. I'll not go into the definitions of it. We can read it out. And this is what the main issue is, and a webinar mainly starts from this. So this is about the AMLA classification. We all know it's been classified as serine beta lactamyces, that is class A, C, D, and the metallo beta lactamyces. So my first question comes regards to this to Dr. Hegde. So, sir, why is it important to identify specific carbapenemase genes, OXO 48 and KBC, and how does this guide antibiotic choice?
So I think basically I'll talk about each of these separately. First, we'll talk about the CRE or the
Yes,
carbapenem-resistant enterobacteriaceae because these are the ones where this really is the most important. I mean, the most important enterobacteriaceae which are carbapenem-resistant in our country are the Klebsiella and E. coli. And unlike in the ultimately at the moment, the prevalent mechanism, the mechanism by which they are resistant to carbapenems is the production of inactivating enzymes called the carbapenemases. Now, the two most prevalent carbapenems in our country are called the OXA and the NDM, or the metalloenzymes. Of the metalloenzymes, NDM is the one that's prevalent in our country. Unlike the West, where KPC also is a carbapenem which is prevalent, KPC is not very prevalent in our country. Now, why is it important to find out, what is the mechanism, what is the molecule carbapenemase that's being produced? At least for the CRA, it's very important because depending on the kind of carbapenemase, your treatment might change. For example, if the carbapenemase tells, if the molecular diagnostics tells you that it's just producing an OXA, then a drug like ceftazidime avibactam is good enough. But if there is also a production of metalloenzyme, classically NDM in our country, then you probably need to have a aztreoname-based combination. So that, of course, some people must still prefer to use colistin-based combination, but preferably you would need to use a combination of aztreoname avibactam or ceftazidime avibactam, depending on whether there's an OXA or an NDM or not. So NDM, obviously, you would have to use aztreoname-based combination. So pure OXA, you can use ceftazidime and avibactam as well, alone. Now remember, this is useful. The most useful is for really the CREs. It is not useful that in carbapenem resistant Enterobacter at all, because carbapenem resistant Enterobacter, unlike the carbapenem resistant Enterobacteriaceae, has mechanism resistance other than carbapenemase production. It produces efflux, there is sporin channel alteration, and the OXA produced by the Enterobacter is different from the OXA produced by the CREs. Therefore, molecular diagnostics are not useful in deciding treatment for Acinetobacter. Sometimes you have a molecular diagnostic saying no resistant mechanism detected, and people think that is very sensitive to Acinetobacter. That's not true. It just means that none of the resistant mechanisms on that panel are there. So it could still be a completely pan-resistant Acinetobacter showing no mechanism resistance on the molecular diagnostic. So again, I must emphasize that this molecular diagnosis is really the most important CRE. It's not that useful for Acinetobacter. Even for Pseudomonas, again, for Pseudomonas, there are multiple mechanisms of resistance, like porin, efflux, etc. But so the idea is to see whether Pseudomonas is producing a metalloenzyme or not. Because if it's producing a metalloenzyme, which unfortunately is the case in the majority of the Pseudomonas in our country, then what is prescribed in the West, like ceftazidime avibactam or ceftriaxone tazobactam, will not work in our country. So basically, like I said, so ultimately, for our practical purpose, in any case, I think Pseudomonas in our country are producing MBL. So I would just like to emphasize that the molecular diagnosis is important only for CREs, and that helps us decide which is the best treatment, whether to use a combination with or without aztreoname. That's probably it, depending on the presence of OXA or NDM or either or both. That's how it would probably help us deciding therapy.
thank you. So thanks for that. So we'll move ahead with our next question. When we talk of the mechanism of resistance, as you all spoke, we have the different mechanism of resistance. Could be the drug uptake limitation, efflux, or drug inactivation, or the drug target inactivation. So my next question For Dr. Todi, so this is a 66-year-old man with post-operative intra-abdominal sepsis is admitted to ICU with septic shock. So blood culture has shown club pneumonia. So how does the ceftazidime avibactam plus aztreonam combination works against NDM producing organism? And does ceftazidime avibactam synergy implies aztreonam avibactam sensitivity as well? This is what we usually test for.
Yeah. Bharat, normally aztreonam is the antibiotic which acts against NDM, but aztreonam is broken by ESBL or beta normal beta lactamase. So that's why aztreonam alone is not going to be helpful against NDM, though it has got activity against NDM. And that's why this avibactam is used as an beta lactamase inhibitor along with aztreonam. So previously we didn't had avibactam aztreonam combination, which we have now. So we used to have ceftaz-avi with aztreonam. The question is, the ceftazidime part of it is probably is not useful because, as you know, the ceftazidime doesn't work against ESBLs and NDMs. So it is the avibactam and aztreonam. So the question now is, now we have availability of aztreonam avibactam in our country. Then comes the which bacteria are sensitive to these. Normally, Klebsiella is the one which have got a good synergy in the sense that if one uses ceftaz-avi with aztreonam, most of the centers are reporting more than 90% synergy, whereas E. coli and Pseudomonas are probably 60-70% synergy. So even if a lab doesn't have a synergy test, if it is growing Klebsiella, and which is NDM in the sense it is carba resistant and ceftaz-avi resistant, as is shown in this antibiogram, one can assume it to be synergy positive, and one can go ahead with this combination. Thus, aztreonam avibactam is better than ceftaz-avi and aztreonam. There are certain logistic problems in giving ceftaz-avi and aztreonam. They both have to be given at the same time, sometimes with a Y connector, or sometimes both are giving in different channel at the same time. They have to be infused because, in the lab, the way the synergy test is done, the two discs are put together and see whether the growth is inhibited, and so it has to work in vitro as well as similarly. So both the antibiotics needs to go simultaneously at the same time, and whether it works once it goes inside the body is not very clear. Another thing is not very clear is there is no break point of this ceftaz-avi plus aztreonam combination. It has never been, CLSI has not come out with a breakpoint as opposed to aztreonam and avibactam. So that also is a positive point to use aztreonam avibactam, which is a single molecule. We don't have to use any other antibiotic along with it for NDM. So there are certain advantages of using aztreonam avibactam along as a monotherapy. The problem comes, as Ashit mentioned, most of the bacteria, even Enterobacteriaceae, one third have NDM, one third have NDM with oxa. So the question comes, we know ceftaz-avi with aztreonam is works against oxa. Ceftaz-avi works against oxa very well. Now, question is aztreonam avibactam, which doesn't have ceftazidime, is going to work against oxa as good as ceftaz-avi, and that is what is still not known, because this is very peculiar to our country. It is only we have to study in patients with oxa and NDM which combination is better. Is it ceftaz-avi plus aztreonam, or aztreonam avibactam is equally good? So these are the things I would like to put it to our audiences. If you go by phenotype, as has been shown here, both aztreonam and ceftaz-avi are resistant. The only thing is the aztreonam MIC is pretty high, But if one does a synergy test, this might come down. And we assume since it's Klebsiella, it's going to work. Or one can, we assume that if it is synergy positive, the Astronam avibactam will work as well. So over to you, Bharat.
Yes, so you mean to say for the MDM, sir, we can use Astronome and Avibactam combination, but as said by Dr. Ashit, sir, one third of the NDM also has the OXA. So if there's a failure in the treatment, then we might consider adding ceftazidime. Is that true?
That's the issue, you see. What we don't know, if we have a bacteria which is pure NDM, Astronome avibactam, I think, is the molecule to go for because we don't require ceftazidime. Question is, if it is pure OXA, we don't require Astronome, we can just go with ceftazidime avibactam. If it is NDM with OXA, which 1/3 of our Enterobacteriaceae have, which is a better choice? Is it Astronome avibactam as a monotherapy or ceftazidime with Astronome? This is still not very clear. I think some of the other panelists might throw light on this. But I think at the present moment, Astronome avibactam as a monotherapy will be a good choice for NDM.
It's a pure OXA, Subhash. I think that ceftazidime avibactam would probably be the choice because
or pure OXA. Or pure OXA.
Because it's potentially less toxic than Astronome.
Yeah. So, but what about NDM with OXA? That's the question.
We have no choice. We have to use avibactam with Astronome.
No. Ceftazidime is good for OXA.
Yeah, but if NDM is there, then Astronome has to be there. There's no question.
That's right. Ceftazidime with Astronome or Astronome, they claim that Astronome avibactam is good enough for OXA as well.
Yeah, of course, because the better pharmacokinetics, everything.
Yeah.
But for a pure OXA, I think ceftazidime avibactam is a combination, probably Astronome avibactam. That's what I would think.
So it becomes that Astronome avibactam might replace ceftazidime and Astronome given separately because it is working against both NDM and NDM with OXA.
We'll go to the next question. That is for Dr. Binila. It's for you. So we have a 58-year-old gentleman who underwent a surgery for pelvic mass involving the right ureter and requiring degestanting. So on post-op day 10, he developed fever with chills and blood and urine cultures show Gru Pseudomonas aeruginosa. So what do we mean by DTR Pseudomonas? And if that is the case, then what do we choose and why?
For the trainee's point of view, the fact that this is a post-operative patient with a ureteric stent who has developed a Pseudomonas aeruginosa and the UTI, I think the most important thing, it kind of raises the concern for a possible, hospital-acquired care-associated infection. And, given the usual trend of healthcare-associated infections in our country, with the presence of a foreign stent, the fact that this will be a difficult to treat Pseudomonas is more likely. And, when you talk about a difficult to treat Pseudomonas, that essentially, refers to, Pseudomonas, which is resistant to the standard first line beta-lactams. And, when I was a PG, we used to treat Pseudomonas with Piptaz and ceftazidime and, cefepime. But now, I think all those are kind of unheard of in the ICU setting, at least. I hope in the ward setting it is still being used. But difficult to treat is essentially for the trainees who are here. It refers to Pseudomonas, which is resistant to the traditional first line beta-lactams. So in this setting, where I have a difficult to treat Pseudomonas with this antibiogram, which I can see here, it's clearly a difficult to treat Pseudomonas, and I would, in this situation, probably choose ceftazidime avibactam. But if you do have the availability of the resources of ceftalozone tazobactam in your situation, that would also be an optimal choice. Sometimes, in situations where none of these are available, even colistin, though I would put that lower down. And I think more important than anything else would be source control. We need to look at, whether there's a problem, whether there's a surgical thing which needs to be drained, if there is a stent whether it needs to be changed. So in this situation, clearly this antibiogram, as I said earlier, my choice would be ceftazidime avibactam. Colistin, it is sensitive, could also be an option which can be used in this situation.
So we'll move ahead with the next question.
The only point I want to make, Bharat, is that if there is an MDA in Pseudomonas, there may be ceftazidime, avibactam, or ceftriaxone may not work, and MBL is quite often prevalent in our country. So maybe in a sick patient, I would think colistin till we get the
Yeah.
further.
Yeah, so we do use colistin. Colistin is quite widely used, definitely here, especially in like where I work in CMC. To get ceftazidime avibactam, it's an ID prescription, and ID has to kind of approve it, which usually takes about maybe about 6 to 8 hours. And as you said very correctly, since this bug you can see is sensitive, colistin would be a good choice in this situation.
So if the patient is sick, then Dr. Hegde wanted to say colistin would be the first choice.
But Bharat, nowadays they don't report sensitivity to colistin.
Colistin, yes, so this is an
So
old
it
report what we
must
presented.
be intermediate most likely, and that is the issue which is coming up, because ultimate the clinical outcome, antibiogram might say that it works. The clinical outcome has not been very good if we have an alternative. Unfortunately, we do not have cefiderocol, but there is a
Yeah.
molecule cefepime zidibactam which is going to be launched in June this year, which will probably be a good antibiotic against DTR pseudomonas.
I was saying that fosfomycin is resistant, so my first choice would have been fosfomycin. But your report says that fosfomycin is resistant. So my question to the audience or the panelists is that can we think of plasmomycin in this situation?
Okay.
Plasmomycin is an antibiotic, which is a very good antibiotic. There has been even one article in NEJM, but it is comparing with carbapenem. Though they are pushing it for as a carba-resistant organism, the penicillin binding protein 3 mutation, PBP3 mutation, is getting more and more common in our country, mainly in E. coli. And that is where all the cephalosporin combination therapy will fail. Even cefiderocol, you take any cefepime and BLI combination is not going to work. The PBP3 mutation will be taken care of by plasmomycin. Question is, how do we identify? Phenotypically, it is very difficult to identify whether, I think if it is pan drug resistant, like in this, apart from colistin being intermediate, we assume that it will have some PBP3 mutation, and especially if we have the genotype of this organism and we are not finding, say, pure MBL or OXA or NDM, something like that, then it will be PBP3 combination. And that is where plasmomycin will definitely play a role.
So, sir, we'll move ahead.
Okay.
Shasi sir, this question is for you. We have a 64-year-old ICU patient with septic shock due to hospital-acquired pneumonia, which deteriorates after day 5 of cefuroxime sulbactam. Blood and ET culture grew enterobacteriaceae complex with likely inducible MC producer. So, what do we mean by inducible versus depressed MC? That is question one. Then, is cefepime a safe carbapenem sparing option? When should we escalate to carbapenem?
Normally, we have AMC being produced, which is sort of constitutive. You're using an analogy with nitric oxide synthase. So normally, some nitric oxide synthase is always produced in the body. Similarly, AMC is also produced. But the question is that under the influence of some antibiotics, we go in for inducible AMC productions, and there are some antibiotics famous for this kind of thing. And the second thing is that the production, this inducible chromosomal mediated AMC, that could be de-repressed or it could be induced to produce too much. Now, normally speaking, in the good old days, ampicillin or even high-dose gentamicin used to be used for this kind of situation. Now, the question is that Enterobacter cloacae in this situation, even if I were to go by the antibiogram or the sensitivity report, it is very likely that it may be resistant to both vancomycin as well as linezolid. So that is why in this situation, what is the antibiotic to use is something that I have to go by the actual sensitivity report that I get from the microbiology lab, and then only I can decide. But inducible AMC production, very, very common in situations where the patients have been on antibiotics for a long period of time. And that is why drugs which are previously susceptible to, Like in this case, it was cephalosporin sulbactam was being given to the patient. Patient was perhaps initially showed some improvement in his condition. Maybe the vasopressor requirement did come down, and it seemed to be doing well. But as the time passed on, because of the cephalosporin component, the AMC got de-repressed, or we can say that inducible AMC became at the center stage, and that is why it ceased to become effective. In this situation, very, very difficult. I would not agree for cefepime as a safe carbapenem sparing option, because I have burnt my fingers by giving high dose cefepime as to the tune of 2 grams three times daily, but it has not worked. So the question is that when we should escalate to carbapenem is anybody's guess. I mean, I would do it immediately, but I would add something else along with carbapenem for a synergistic effect, and that could be something like amikacin. That's my answer.
So anyone else? We all agree with this, all panelists?
This plethora of BLBLIs with cefepime as a backbone antibiotic is mainly pushed because of the AMC. Now, question is, what is the incidence of AMC in our country? The epidemiology which I have gone through, AMC production is not as common as OXA, NDM, and other ESBLs. And what worries me is the cefepime as a backbone, especially if we are giving at a higher dose, is the neurological manifestations, which will probably come to light once we start using it more and more. Because we have not been using cefepime as a cephalosporin of choice because of this neurological problem. I think time will tell. A lot of our patients have renal dysfunction. They have already neurological disturbances. How safe will it be to use cefepime as a backbone, as a as a beta lactam along with BLIs? So that is, I think, we'll have to keep a watch on. So carbapenem might be a choice, especially with the side effects. But if I can get away with cefepime only in a patient who is otherwise have a normal renal function, doesn't have neuro problem, should be all right.
So, Monalisa, this is for you. Welcome to our webinar. So, she's an ID specialist. So, Monalisa, as per the recent CLSI guidelines, cholesterol is no longer reported as susceptible. Dr. Todi raised this point initially and is always categorized as intermediate for most gram-negative organisms. So, in this context, where does cholesterol still fit in our therapeutic armamentarium in the ICU, and in which clinical situation would you still consider using cholesterol today?
Thank you, Dr. Bharat, for giving me an opportunity, and along with the other reward speakers whom we have been looking up to since years. Pertaining to this question, as we know, the colistin, there have been several concerns about it since long, like the variable pharmacokinetic and pharmacodynamics of the drug, and the reproducibility of the susceptibility testing, like the disc diffusion is not a kind of which we look at, and the microbroad dilution should be done, and the reproducibility test is difficult. So the CLSA has come up with stating it as intermediate rather than sensitive. In our current armamentarium, we have certain situations where we still go ahead with this colistin or the polymyxin B, like in cases where it is confined to the renal, the cystitis due to the carbapenem resistant enterobacterial, or the in a hospital acquired infections, like due to the crab or DTR pseudomonas, we go with the colistin, but in rest all of the indications we go with the polymyxin B. So the conditions where we may use a polymyxin B in combination with the other drugs, polymyxin B usually should not be used alone. And in the cases indications other than the renal, like if it's a ventilator associated pneumonia caused by the carbapenem resistant acinetobacter or the DTR pseudomonas, we may go with a combination therapy with the polymyxin B along with the sulbactam or tigecycline or aminocycline, which is susceptible. Then coming for the other indications, like where we have a meningitis, post-surgical meningitis or hospital acquired meningitis, in those conditions we use if it is caused due to a crab in like the carbapenem resistant acinetobacter, then we go ahead with using intrathecal colistin along with the the IV colistin along with the TG or amino which is susceptible, and sulbactam. And if it is a HDR cleb in the CNS meningitis, then also we go with the intrathecal colistin along with the avibactam aztreonam IV. And also in the cases where we have a E. coli with the PBP3 inserts and NDM, in those cases we go with the combination therapy of fosfomycin with polymyxin B or colistin.
Yeah, so very nicely summarized, Monalisa. So we'll move ahead, and the next question is, sir, for Ashit Hegde, sir, for you. I mean, he's very busy and involved in the chat box, which is thank you for that. So in severe MDRO gram-negative infections, particularly CRE and CRAB, what is the current role of tigecycline? So is it as a salvage agent? Can we use it as a monotherapy, or it only has to be a combination therapy? And what is its influence, especially in case of bacteremia?
I'll talk about the PKPD first. Now,
Yes, sir.
tigecycline is supposed to be a lipophilic antibody. Lipophilic means affinity for fat. Therefore, it does a distribution to all the tissues of the body, especially the skin, soft tissues, abdominal viscera, etc. Because it has such a high volume of distribution, the final concentration in the blood is quite low. Therefore, it is not recommended routinely for bloodstream infections because its final concentration in blood is quite low. In fact, the pathologist in our hospital, we're not allowed to report tigecycline sensitivity because when they came for accreditation, they said you cannot report tigecycline sensitivity. It's not meant for bloodstream infection because it has low concentrations in the blood. Having said that, that's okay in the West, but in our country, when we have so much of resistance, can we really do away without tigecycline? I don't think so. I think at the moment, the situation where I would use tigecycline really is an empiric therapy when I'm suspecting a carbapenem resistant infection, but I don't know whether it is Acinetobacter or it is a CRE. So until I get more information, empirically, I probably used polymyxin plus tigecycline high dose. I've used a high dose tigecycline, which means 200 milligram loading dose and 100 milligram twice a day till I get more information. So at least initially, empirically, I would use maybe polymyxin with high dose tigecycline. If it turns out to be a CRE, I'd probably switch to a ceftazidime avibactam aztreonam or avibactam aztreonam combination. If it turns out to be Acinetobacter, I would then probably switch to minocycline instead of tigecycline because probably for Acinetobacter, high dose minocycline has better pharmacokinetics, better penetration than tigecycline. So at least empirically, I would use tigecycline, but once it comes to directed therapy, I would probably have no role, at least for bloodstream infections and pneumonia, but maybe for intra-abdominal infections caused by CRE, which are sensitive, I might use tigecycline because, like I said, tigecycline has very high levels in the abdominal viscera, and so if it is sensitive or borderline resistant, that might be one indication, but I might use tigecycline.
So in case of bacteremia, sir, has it got some relation with the MIC? There have been certain
because it's a high volume of distribution, the concentrations in the blood are quite. So you're not allowed to report it at all. You're not allowed to report sensitivity. That's the trouble.
So, Ashit, do you use the standard dose or double dose of?
Double dose, 200 milligram loading dose and 100 milligram BD.
Okay.
Maybe for bloodstream infection.
Ashit, I've got a question to you. That tigecycline especially, it is known that the bacteria develops resistance while the patient is on tigecycline therapy. Let us say it was started because it was sensitive. And that is why I generally do not believe in giving tigecycline for longer than 5 days. And I really appreciate the point that you made that in case of a crab, your preference would be minocycline rather than tigecycline. I completely agree with that.
Yeah, so it's empiric and usually combination, almost never monotherapy, except maybe for CRE abdominal infections.
And I think it also depends upon the source, na? If it is abdominal infection,
Skin and soft tissue infections,
skin,
probably.
soft tissue, TG is really good in those kinds.
TG is used, yeah.
But in the bacteremia, we should avoid it or not use it at all.
Avoid it. It's not the guidelines do not recommend tigecycline in bacteremias. But as
Oncologically,
in our country, if we have no other choices, colistin is toxic as well. So high dose tigecycline might be an option as a combination therapy.
Binila, you wanted to say something?
no, I was just saying that the same thing which Dr. Ashit had said. It's being lipophilic. It tends to be more bacteriostatic than cidal. So for a patient with bacteremia, I definitely would not, be, in the ICU. I would not prefer tigecycline.
So move ahead. So next question is for you, Dr. Todi. So fosfomycin often considered for MDR gram-negative infection, but where does it truly fit in ICU practice? Should it be only for the uncomplicated UTIs? And what is the role of intravenous fosfomycin? Does it have any meaningful role in CRE infections when used in combination?
6, 7 years back, I used to use IV fosfomycin for pyelonephritis and all. But given the recent antibiotics that we have in our armamentarium, and the recent, even the guidelines say IV phosphomycin does not have a penetration into renal parenchyma. So it is not advocated for pyelonephritis unless we have an organism to which everything is resistant to. It's only sensitive to phosphomycin and colistin. Then you have to give phosphor should not be used as a monotherapy. It should be used as a combination therapy, and as just like in TG cycline, the bacteria do get resistance while on phosphomycin. So by and large, I have restricted use of phosphomycin only to cystitis and not to give IV phosphomycin. I have not used IV phosphomycin over the last few years. Over to you.
And I'm sure, Dr. Todi, the problem of hypernatremia also
Yeah.
deters you from using it further now.
Hypernatremia, potassium disturbance, volume phenomenon. So a lot of other complications are there, but those are still manageable. But as just from a microbiological perspective as well, given that we have ceftazidime now, aztreonam, avibactam, I don't see a particular role for intravenous phosphomycin.
No, the problem
We have a
Subhash is for PV penicillin binding PV3 insert. There, you have no choice at the moment. You have to use
Only
phosphomycin.
thing, plasmomycin, if renal function permits, will be a better choice because
No,
it's
but as somebody mentioned in the chat, see the aminoglycoside, there is something called a 16S methyltransferase gene, which is there with all the NDMs. So in that situation, the aminoglycosides don't work. So unless we have definite evidence that plasmomycin is sensitive, we cannot use it empirically. Because most of these NDMs have a 16S methyltransferase gene, which destroys at least in our hospital, we found that when plasmomycin is sensitive, even amikacin is sensitive. There's almost no situation where amikacin is resistant and plasmomycin is sensitive. So in that case, why use plasmomycin when amikacin, which is much cheaper, is available?
I think there are few aminoglycoside modifying enzymes to which amikacin, tobra have got very high MICs, to which plazo is sensitive. That's why it has come into the market, because the aminoglycoside there are quite a few aminoglycoside modifying enzyme which is only sensitive to plasmomycin. So I think there is a role for plazo for PBP3 mutation. And whether IV phosphomycin, because the penetration of if you're talking about pyelonephritis, the penetration of this molecule into the renal parenchyma, the latest IDSA MDR guideline, they are living guidelines, so they keep on updating it every few months, has categorically mentioned phosphor does not have concentration into renal parenchyma and should be avoided for pyelonephritis.
So coming to that only, sir, usually we have a patient of pyelonephritis in shock, maybe on single vasopressor or multiple vasopressor. Now the report is come which shows colistin intermediate sensitive as per the CLSI guideline and phosphomycin sensitive. So what should be the therapy? Monotherapy colistin alone, monotherapy phosphomycin alone, or have to go for the combination?
No, why not using ceftazidime, aztreonam? It works well with pyelonephritis. Why do we have to go for phosphor, colistin? We are talking, acinetol as a cause of pyelonephritis will be very unusual. So we are talking about Enterobacteriaceae or probably Pseudomonas. So I think those combinations should work well in this. We don't have to go for phosphomycin.
We'll move ahead, and next is for Dr. Binila. This is for you. So 62-year-old man with diabetes admitted to ICU with septic shock secondary to severe pneumonia is intubated and mechanically ventilated. On day 6, he develops new fever, worsening oxygenation, and endotracheal aspirate, as well as the blood culture grew Burkholderia cepacia complex. So what is the drug of choice in this case? Is combination therapy always required, and when do we suspect pseudo outbreaks as well?
When I see Burkholderia cepacia in the ICU, it's something which I will always have my antennae up as to whether it's a colonizer or whether it's actual infection. And because, there are several times when we know that Burkholderia cepacia is, it grows in, one common place is the ultrasound jelly, which is widely used in the ICU, in water, in nebulizer solutions. It's there in a lot of places. So we really need to, take a conscious decision as to whether this is because whether it's infection or is it a colonizer, is it an outbreak, pseudo outbreak, as you were saying. When you say pseudo outbreak, it's most likely you will see many patients in your ICU having the same isolate with the same kind of resistance pattern, and that's when you must suspect a pseudo outbreak. So I thought I would start with that question. Having said that, there are situations where we have treated it, where we don't, especially when this is a patient who's clinically deteriorating, has developed new fever, worsening oxygenation, most probably has developed a ventilator-associated pneumonia. Actually, in my practice, I would actually like to know what the, how many pus cells, colony-forming units are there in the ET aspirate before I really comment and say that, okay, this is a VAP, which I would treat. But in the situation, if there was no other cause of the fever and the worsening oxygenation, I possibly, would this. I'm just looking at that. This CEFTA is sensitive, so that's a good thing. But I mean, I would, request the my co-panelists to give their choice. I wouldn't mind giving ceftazidime in this situation. Bactrim, it's also sensitive. Whether I would use a combination of ceftaz Bactrim in situations where I have, a person with immunocompromised patient, maybe with shock, I may consider combination therapy, but I wouldn't always give combination therapy for this infection.
We are getting more and more bacteria in ICU like Burkholderia, Elizabeth Kinglias, and the others, because they are all intrinsically resistant to colistin. And because of rampant use of colistin and polymyxin at one time, we are having more incidence of these kind of bacteria. The second thing is we are getting better with hand hygiene, but not with water hygiene. And this Burkholderias and all, they love contaminated water. And that is where I think we are getting more incidence of this. I have seen more Burkholderia in, say, central line, rather than VAP. I would say central line infection, dialysis, catheter infection. And we have been using minocycline most of the time, a high dose minocycline for Burkholderia. Over to you, Bharat.
Yes, sir.
Burkholderia cepacia, cornocepacia, or so many of these species, they generally are not positive on day 5 or day 7. Generally, they are seen in patients who have been on prolonged antibiotic therapy, and maybe they have develop secondary infection. I would agree with Binila that more often than not, they are colonizers. But if they have come about at least 15, 20 days or even longer that the patient has been in the ICU, then I'll have to consider it. And generally speaking, I talk to my microbiologist and we tend to tell them that there's something of this kind is coming up. And generally speaking, we do come across pseudo outbreaks. And that's why we tend to do this investigations and outbreak investigation is put in place. But we have not been able to find the reservoir. It's very easy to say that contaminated water is one, but there are very few occasions that we would use them, unless, of course, Burkholderia cepacia is in the sink of the hospital. That is a different matter. But Burkholderia cepacia coming through on the day 5 is something that I will take it with a pinch of salt. I would presume it to be a colonizer and then resist from treating it and waiting and maybe just see how it goes.
Hegde sir, you wanted to make some point?
The only point I said is that sometimes you have a BCID panel showing blood culture growing gram-negative bacteria, but the BCID panel saying nothing grown. So this is so Burkholder. That time is when you suspect all the so-called off-panel organisms, where the blood culture has flagged the gram-negative, but the BCID panel says no organism seen. So you don't blame the BCID panel. It's just that it's not on the panel. So that should make you suspect that this is Burkholderia or Kingelia or one of those funny things.
So, Dr. Monalisa, this is for you. So, newer drugs for MDR gram-negative pathogens. Could you please tell us about the mechanism, targets, and what are they useful? When are they useful?
So these MDR GNVs, they have been like a great concern, and we are discussing about it. And we currently have a few drugs in the pipeline, and the drugs which are available with us, of the newer one is the Avibactam astronam. That like already has been discussed in detail. So this Avibactam astronam is helpful in the cases where we have like the NDM along with the OXA48, and with the coming of this like the molecule, the Emblavio, the Avibactam astronam, the only indication where we use the ceftazidime avibactam with the astronam would be only ceftazidime avibactam alone would be only where OXA48 alone is present. So coming to the other newer molecules which are there, the cefepime zidibactam is the one which is more like would be the game changer, which when it is like launched, when like, so this cefepime zidibactam that is to come, we have already used in compassionate basis on like 4 of our patients, and it has like multiple dual mechanism of action, inhibiting the cell wall synthesis directly, as well as acting on the PBP2 and PBP3. So it has got a broad spectrum of action, including the carbapenem resistant Acinetobacter, which is not at all covered by the ceftazidime avibactam with astronam. It also covers the Pseudomonas, difficult to treat Pseudomonas, which have got other mechanism of actions like the efflux pumps and the porin channels. And also, the by about 5 to 10% of the XDR Klebsiella, they have got newer mechanisms of resistance like the plasmid mediated CMY4, which renders it resistant even to the ceftazidime avibactam astronam combination. Even in those cases, this cefepime zidibactam would be very helpful. Coming to the other newer molecules, the other BL-BLI combinations that are there include the meropenem favorbactam, the imipenem rilebactam, which are yet to come. They are not available with us. The other one which is to come next year is the nacubactam. The cefepime nacubactam, we can use it, or the astronam nacubactam we can use. That would be very helpful in the cases, and about 90 to 95% of susceptibility has been shown in the enterobacterials. The other molecule, the cefiderocol, which is already there in the Western countries, it would we have to see its efficacy in our country, where the NDM is a major concern, and it inhibits only the NDM1, whereas we have the other NDMs also, which are significant in our country. So the studies have shown that the cefiderocol would be around some 40 to 50% susceptible in our isolates. So we would require maybe to combine the cefiderocol with the astronam for most of our isolates. And the sulbactam darlobactam is a good choice for the Acinetobacter, but we do not have with us. So we use only sulbactam-based therapy along with the polymyxin B. So these are the newer molecules. And even we have the plazomicin, as already Todi sir has discussed, it is indicated for the PBP3 insert in the renal indications. So this aminoglycosid is also good for the cases where the PBP3 inserts are significant.
Okay, Hegde sir, this is for you. So, as we discussed about the newer antibiotics, so will cefepime zidibactam replace astronome-based combination? And if we have to compare with the cefiderocol, how is it? And is it the true pan-carbapenemase drug that may eventually replace cefiderocol, or cefiderocol remains superior because of real-world data and established approval? And what is the evidence in CRAB?
See, at the moment, I think the real problem we have in our country is the resistant Pseudomonas aeruginosa, for which really don't have any great drug. So I think one role we have for cefepime zidibactam is clearly for the carbapenem resistant Pseudomonas aeruginosa. For all the enterobacteria, we already have astronam avibactam, which work pretty well. So at the moment, I don't think I would use cefepime zidibactam for the routine CREs, unless, of course, it's a salvage therapy. For Pseudomonas, definitely I would use it. For Acinetobacter also, we have combination of polymyxin, minocycline and sulbactam. So again, there also I would use it as salvage therapy. There, the question is whether you would use cefiderocol versus, or you would use cefepime zidibactam. Now, though cefiderocol is supposed to be useful for all the three, Enterobacter, Pseudomonas, Acinetobacter, there was some study, a small study of course, where actually for Acinetobacter, in the sickest patients, the mortality was higher when the patients who got cefiderocol versus colicin therapy. So actually, the IDSA have been a little cautious about using cefiderocol for Acetobacter in ICU patients. So at the moment, I would think the only situation where I might use Zidibactam, probably more cefepime Zidibactam, because it's probably going to be cheaper than cefiderocol. So I might use that only for the difficult to treat Pseudomonas aeruginosa. For all the rest, I would continue to use what we're going along with, not maybe as a salvage therapy, not responding, I might use them, but not otherwise. But routine therapy would still be what I'm already using.
The Bharat, the main apprehension I have with cefiderocol and cefepime zidibactam for targeted therapy, I think we are okay. But they are such a broad spectrum antibiotic. Use of empirical use of this might become even more prevalent in our country where we don't know which organism are we dealing with, and that will cause resistance to these antibiotics pretty soon because they are such a broad spectrum antibiotic. So we don't have to use any combination, just use this molecule. It will cover NDM, OXA, ESBL, and everything. And that's very scary in a way that we might be using it empirically to cover bad infections. Over to you, Bharat.
So, Shastri sir, this is for you. Now, since we are almost discussed everything, we are almost trying to compile it. So, when managing VAP in the ICU, what factors should guide our empirical antibiotic choice, local antibiogram, prior antibiotic exposure, duration of hospitalization, severity of illness? So, how broad should our initial coverage should be?
Well, you mentioned almost all the indications for the choice of antibiotics. And for me, the most important one would be my hospital antibiogram, because we have wonderful reports coming from our microbiology lab saying that these are the most common bugs that are growing in your ICU, especially in your ET aspirate. And these are the drugs which they are either sensitive to or resistant to. So for me, the information that I have from a hospital diagram would be the reason for me to choose the antibiotics. Now, in this case, in my hospital, most of the time the ventilator-associated pneumonia is due to Klebsiella pneumoniae. Very rarely it is E. coli, and 99% of the time it is carbapenem resistance. So for me, at least to begin with, I would go for Cas-IV combination in fairly decent doses, or if I do get the molecular diagnostics telling me that these are the particular enzymes which are the mechanism of resistance, I would go for Avibactam Astrinum combination. But at the moment, our practice, including my colleagues' practice in the ICU, is to go for Ceftazidime Avibactam plus Astrinum combination, which seems to be the drug of choice when it comes to Klebsiella pneumonia, which is the most common VAP that is seen in my ICU. Over to you.
Yeah. So there's a request from Dr. Rowley. She's asking if we could once more reiterate a drug of choice therapy for Burkholderia, mono or dual. Ashit sir, you can take this.
Why?
Yeah,
No,
yeah.
I think at the moment it should probably be combination therapy. Maybe drug of choice should be cotrimoxazole, and you might combine it either with ceftazidime alone or Taz-IV Astronine, meropenem. That's the other drug you might combine it with is minocycline, but ultimately better to use combination therapy because resistance is happening more increasing. So I think one will probably Ceftriaxone in combination with either meropenem, Taz-IV Astronine, or minocycline. Some people add levofloxacin, but these are the potential combinations that you could use. But ultimately,
Ashit, in the good old days, they were always telling about fluoroquinolones being used in
levofloxacin,
Burkholderia.
levoflox.
Yeah, would you agree for that at
But
present
I would
situation?
empirically, I might not use it. Once I get sensitivity
Yeah,
back, maybe yes. But empirically, I would
but I
probably use
don't. In my hospital,
the
I don't
Ceftriaxone
get
with,
sensitivity to. I don't get
I would use
sensitivity
Ceftriaxone
to
with
fluoroquinolones.
I would probably use
Yeah,
Taz-IV Astronine with Ceftriaxone in a really
yeah.
sick patient. See, ultimately, it all depends on how sick the patient is, how much you can afford to be wrong. In a really sick patient, very kind of obviously, I'd probably use Taz-IV Astronine and Ceftriaxone. If it's not so sick, maybe I could try a lesser drug.
So we'll move ahead.
Right.
Dr. Binila, this is for you. So this is about the catheter-associated urinary tract infection critically ill. So how do we decide empirical antibiotic therapy, and should we routinely cover for the resistant gram-negative organisms? Can therapy be guided by the clinical risk factors and local resistant patterns again?
So I think I'm getting a lot of the trick questions, which are, which I would say in ICU are big challenges. Because when you look at catheter-associated urinary tract infections, from what I have seen in my experience in our hospital and from research that we've done in our hospital, generally tends to come in by the third week in ICU, which yes, I mean like those are, I mean we would have a high alert that okay, fine, if you've got a catheter in place for more than 2 weeks, third week starting, you have fever, it is possible that the catheter may be a source of infection in that situation. But I would always err on the side of confirming that really the source of the infection is the catheter before pointing a finger at the urinary catheter and saying that's the cause of the infection. With regards to, suppose the patient does have pyuria and cultures are the colony forming units are in favor of a possible urinary tract infection. I think I would, the question of how we decide empirical therapy and whether we should routinely cover for resistant gram-negative organisms. In my practice, I would say that we do not routine. I mean, I think really we are each hospital should be guided by the kind of organisms which are there in their setting. Yes, when you see a patient in our Indian ICUs for more than 2 weeks, it is a very high chance that the organism will be resistant gram negative. It is possible, yes, in our setting. So what would I choose in that situation? One is I would think about whether I can get rid of the catheter, and secondly, look for complications, assess whether the patient has any features of clinical deterioration, septic shock, and then I think all the choices of antibiotics that we have talked about. In my situation, we tend to see a lot of Klebsiella, Pseudomonas, and E. coli. Occasionally, we do see some ACBs which are coming in the urinary catheter. So, really, my choice of antibiotics would be guided, would be broad initially, and I would narrow it down based on the culture sensitivity. If you ask me, in my setting, what would I use? I think given that we do have a high incidence of carbapenem resistance, I possibly would be using maybe either a combination of colistin with or Ceftazidime aztreonam with plus minus colistin, if at all, based if I'm 100% sure that this is the source of infection for the patient. So, I mean, but really the choice should be guided by your local antibiogram as well. So it's multiple factors put together. I would say the risk factors, the severity of the patients, and local antibiogram should guide your therapy for patients with suspected COTY.
Another point to look for is the prior carbapenem exposure. The way I usually manage, if a patient doesn't have a carbapenem exposure history, then probably carbapenem could be the first choice. But if the patient has carbapenem exposure, one has to go for ceftazidime or plus minus aztreonam.
Binila, most often that we come across in this kind of complicated situation is something like Serratia marcescens, something like Proteus mirabilis. I mean, these are holes in the spectrum of colistin therapy, and I suspect that because of the overusage of colistin and polymyxins, these are grown in the ICU 3 weeks down the line, as you mentioned. So, in these situations, for me at least, colistin is out of question. I would not use. I agree that colistin uh, is concentrated in the urine, all right, but at the same time, these are the holes in the spectrum of colistin, and that's why there's no question of using it. And I would agree with Subhash Todi that possibly I would go for the combination of Cazavi plus
Yes.
Astronam in these situations.
Yeah, exactly. I agree completely, because as I said, generally most of the patients are in their third week. They have been exposed to carbapenems. Most likely they will be resistant to carbapenems, and I think that is the choice that we have to do. But de-escalate once you see the culture reports, if possible.
So we'll move ahead, and when we talk of the rapid diagnostics, there are various of available. I'll not go into the detail of this as we are running short of time. So, Dr. Monalisa, there's a question for you. So when you talk of the BCID versus MALDI-TOF, so what different information they provide, and how to sequentially incorporate them in clinical practice?
The advanced diagnostics definitely play a major role in identifying the resistance mechanisms that are harbored by these bugs, and they can very much help in the antimicrobial stewardship. So, the BCID panel is basically a film array, like a multiplex PCR, which determines a fixed set of organisms which it is intended to, like around 5 species of the Candida. And if the person is harboring any of these bugs, only then it would be flagging a positive. But the Malditov, it has got a wide array and it can detect multiple, like millions of organisms and even multiple infections. And it is based on the protein fingerprinting by the mass spectrometry. The mechanism is totally different. So for the BCID, we can when we take it is only on the blood cultures, and when the blood cultures are incubated, when they flag positive on that blood culture, do a gram stain in which we identify whether it's a gram negative bacilli or a gram positive. And then further ahead, the BCID gives the identity of the organism within a period of maybe 1 hour, and also the main resistance mechanisms like the enzymes KPC or OXA48, the MEK-A and VAN-A, VAN-B gene, they can be detected. So we can go ahead making the choice of the antibiotics depending upon the organism isolated. And the Malditov requires a positive isolate from the culture plate to identify the organism, and further 1 more day to get the AST. So in both of them can be used in a layered multiplex, like in the sequentially in determining the septic patients, or those those in septic shock or the immunocompromised patients where we require early diagnosis and proper therapy would result in a better outcome. In those cases, we can go ahead initially with the BCID on the positive blood culture, and then further ahead the culture going into the Malditov for the detailed species identification, and then the AST. Sometimes the BCID would be flagging negative if it does not include the organisms like already discussed, the Burkholderia or the Elizabethakingia. We would suspect those, and they would be identified on the Malditov.
Got it. So Todisa, as we discussed about the BCID versus Molotov, and she's covered all these points. So this is for you. So BCID negative, but organism grown in instances is phenotypic resistant the same as AST, and the clinical failure despite susceptible AST. What is the role of heteroresistant inoculum effect?
That's a loaded question. Inoculum, let me go from backwards. Inoculum effect at one time, it was a theoretical concept, that in the sense that if you have like in the lab, we have a standardized inoculum. But in the body, somebody with a severe septic shock, they will have very heavy growth of organism. So will the antibiotic be working as the same as in the lab? So that's why the term inoculum effect has come, that if there is more inoculum, probably it might not work. And it worked, it was for piperacillin tazobactam. That was thought to be a mechanism, though it was sensitive in the lab, may not be working so well clinically. So that was the inoculum effect. But nowadays, it has been found with this newer BL-BLI combination, the inoculum effect is probably not that great. And the heteroresistance is the one which was mainly described for, staph aureus infection, where you have a mixed colony of some colony sensitive, some colony partially resistant, some colony fully resistant. So gradually the fully resistant colonies starts growing up. Again, for gram negative, heteroresistance are not very well described. As regards the BCID negative but organism grown, in the sense that if you have a gram negative organism growing and BCID is negative, then this will be one of those esoteric organism, as has been mentioned, Burkholderia or Elizabeth Kinglia. And phenotypic resistance, the same as antibiotic susceptibility testing. Do you mean that when we get a genotypic resistance, does it reflect on phenotypic antibiogram? Is that correct, Bharat?
Yes, sir.
So I think the problem comes especially if you give a lower respiratory tract and other. You get so many of resistant genes, and you get many bacteria. Now we don't know which bacteria contains what resistance gene. And ultimately, it is the phenotype which will give us an idea of that which of this genetic was expressed, which of this resistant gene was expressed in the bacteria. So not all genetic resistance mechanisms are expressed by the bacteria. And that is where I think the phenotype is still very, very important. So genotype and phenotypes does not always go together. And I think it is very important. Yes, we can choose empirically. Many a time it is the negative predictive value. If you are not getting Acinetobacter, if you are not getting NDM, chances of having NDM in the phenotypic resistance pattern is very low. But positive predictive value is not very high. We get many resistance genes and maybe only one of the gene. We might have CTXM, we might have OXA, and might have NDM. And in phenotype, it is only ESBL. It might be sensitive to carbapenem. So I think they are not concordant, these two mechanisms. Over to you, Bharat.
So we come to the last question of this session, and this is for Dr. Shastri. Sir, antibiotic pressure we all know drives ecology. So how should prior antibiotic exposure influence empiric antibiotic choice in a subsequent infection?
I talked about the holes in the spectrum of cholesterol. And obviously, there are holes in the spectrum of beta-lactam antibiotics. There are holes in the spectrum of now aminoglycosides. So the idea that previous antibiotic exposure has taken place, then these holes in the spectrum, fancy bugs like Stenotrophomonas multifida, Burkholderia cepacia, Elizabeth meningoseptica, Elizabeth Kingia meningoseptica. I mean, these are the ones which come about, which are selected out by the previous antibiotic exposure. And that is why previous antibiotic exposure is an important component when we are deciding whether we have to give which antibiotics we have to go. That goes very well with the fungal resistance also. The patient who has been on azoles, it is very likely that the next candida that the patient would grow would be Candida auris. And Candida auris, as we know, is resistant to azoles completely. So that is why the prior antibiotic exposure is something that has to be factored in when you are deciding the choice of antibiotics in the present episode. And that is only because of the fact that prior antibiotic exposure, because of every antibiotic has holes in the spectrum. That's why these holes in the spectrum are those are bacteria which survive or which are inherently resistant to that antibiotic. And I named a few which are resistant to carbapenems, which are resistant to colistin. So these are the ones which tend to be selected out and express themselves, and then they become the predominant organism causing the infection in that patient. Having said that, prior antibiotic exposure and growth of these organisms, these fancy organisms, as Dr. Todi mentioned, probably leaves me a food of thought. Do I need to give more antibiotics to the patient to take care of this fancy organism, or should I stop the previous antibiotic that the patient was on and hope that when the natural flora regrows and these organisms that we talked about, Stenotrophomonas multifida and all that, they are fastidious organisms, and these fastidious organisms may not survive the onslaught of the natural bacteria which tend to grow once the antibiotics are stopped. So I am leaving you in a kind of a flux kind of situation. Do you stop the antibiotic or you bombard the patient with new antibiotics? Ultimately, the decision will be based upon the clinical condition of the patient. If the clinical condition of the patient is sick, then obviously you can't afford not to give them antibiotics. But if the patient is reasonably stable, I would probably just give an antibiotic holiday of 48 hours, regrow, reculture them, and possibly decide what is the next course of action. Thank you.
So we've come to end of this session, and the take-home message, as we all understood, mechanism is enzyme-driven. It's not only enzyme-driven. So match the drug as per the mechanism. Rapid diagnostics accelerates precision, but BCRD detects pathogen-resistant genes, while multi-talk tells us about the organism. So antimicrobial resistance is a stewardship challenge. Using diagnostics wisely and preserving new antibiotics is a shared responsibility. Thank you, everyone, and thank you to all the panelists for the valuable insights